يا فندم.
شرف لنا يا فندم. اتفضل سعادتك يا استاذنا، ربنا يكرمك يا استاذنا.
All fractures of the tibia involving the distal articular surface should be classified as Pilon or Plafond fractures, except for the medial or lateral malleolar fractures اللي هيتكلم عليها أستاذنا الدكتور محمد شافعي، والترايماليولار fractures. Trimalleolar fractures لو الانفولفمنت بتاعها involved أقل من ثلث الارتيكولار 1/3 of the articular surface of the distal tibia. The tibial plafond, the distal end of the tibia, including the articular surface. Its proximal limit is about 8 to 10 centimeters from the ankle articular surface. Plafond fractures is very common. It accounts for 7 to 10% of all tibial fractures. They are mostly due to high energy mechanisms. Thus, concomitant injuries are association of concomitant injuries is common. To occur most commonly in the age of in men at the age of 30 to 40 years. The mechanism of injury. The position of the foot during the impaction affects the shape of the fracture. When there is plantar flexion, the posterior lip of the distal tibia may be fractured. With dorsiflexion of the ankle, the anterior lip fragment is fractured. At the impact site, at the impact, the ankle is in neutral position, the anterior and posterior fragments are broken. Mechanism of injury. Axial compression due to fall from a height, shearing accident, as in skiing accident. In axial compression, the force is axially directed through the talus, from the ground to the talus to the tibial plafond, causing impaction of the articular surface. So it is associated with significant comminution. If the fibula remains intact, the ankle is forced into varus with impaction of the medial plafond. Plantar flexion or dorsiflexion of the ankle at the time of injury results in primarily posterior or anterior plafond injury respectively. When the mechanism of injury is the shearing mechanism, it is a mechanism in which there is torsion combined with varus or valgus stresses. It produces 2 or more large fragments and minimal articular comminution. In compression type, there is severe comminution, significant comminution, but in shearing type, there is minimal articular comminution, 2 or more large fragments. There is usually an associated fibular fracture. The fibular fracture, as it is seen, is transverse or short oblique fracture. The mechanism may be combination of compression and shear. These fracture patterns demonstrate the components of both compression and shear, and the amount and the degree of comminution depends on the vector of these 2 forces. Clinically, the patient presented non-ambulatory with variable gross deformity of the involved distal leg. Full trauma evaluation and survey may be necessary. As we said, this fracture is associated with high energy trauma, so the associated injuries must be evaluated. It may be associated with fracture of the calcaneus, fracture of the tibial plateau, hip joint fracture and dislocation, spine fracture. Also, the neurovascular status of the patient of the leg must be carefully assessed. Swelling often is massive and rapid. The soft tissue envelope in this area is little soft tissue, massive and rapid swelling occurs. Serial neurovascular examination should be done. Assessment of the skin integrity, necrosis, and fracture blisters. Meticulous assessment of soft tissue damage. Significant damage occurs to the thin soft tissue envelope surrounding the distal tibia as the force of impacts are dissipated. With clinical assessment, plain radiography plays an essential role. Plain film is centered on the ankle as well as over the tibia. The entire tibia should be, X-rays for the entire tibia should be present. Ankle films, anteroposterior, lateral, and mortise views delineate the articular incongruity and fragmentation. Tibial films necessary to evaluate metaphyseal and diphyseal extent, as proximal injuries may easily be overlooked. X-rays with traction, as traction and ligament taxes will displace the fragments back into position, allowing for better definition and understanding of the fracture pattern. CT is essential as a guide for articular assessment of the articular injury, for fracture orientation, fragment location, and the amount of comminution or impaction. It aids in surgical decision making. As we see, fragment number 1, number 2, number 3. 3 main fragments. The first one, fragment number 1, is anterolateral fragment called Chabot fragment. The posterolateral one is called Volkmann fragment and medial fragment. These 3 fragments vary in size and amount of comminution. Three important anatomical zones in the evaluation of fractures of the tibial, important in evaluation of fracture of the tibial plafond. The articular surface, the metaphyseal area of the distal tibia, and fibular fracture. Because of their high energy nature, as we said before, these fractures can be expected to have associated injuries: calcaneal fractures, tibial plateau, pelvic fractures, and spinal fractures. Plafond fracture are classified by Rudy and Elgohary, which is a commonly used classification today. This classification is based on the severity of the comminution and the displacement of the articular surface. Severity of comminution and displacement. Type 1, 2, and 3. Type 1, non-displaced fragments. Fracture cleavage lines, but there is no displacement. Type 2, there is displacement, but this displacement is minimal with little impaction or comminution. Type 3, there is significant articular comminution and metaphyseal impaction. Ovadia and Beals added types 4 and 5. Type 4 with metaphyseal fracture and type 5 with diaphyseal involvement, with more severe comminution, which is characteristic of many high-energy injuries. The prognosis of these fractures correlates with the increasing grade. That's to say, type 5 is more severe and less better prognosis than type 1. AO and OTA classifications, these are more comprehensive classifications. They are commonly used for research, comparison in research. Type A, B, and C. Type A, extra-articular fracture. Type B, partial articular. And type C, complete articular fracture. The management of Plafond fracture includes many challenges, like difficulties in anatomical reduction of the articular surface, instability, which may be due to ligamentous and soft tissue injuries. Numerous soft tissue complications may be encountered during the treatment. Open surgery is associated with poor wound healing. Restoration of the anatomy is difficult, and delayed union and infection are common. Factors dictating the treatment strategy. Factors related to the patient, like patient age and his functional status, his or her functional status. Factors related to the bone, to the severity of injury itself, like severity of injury to the bone, cartilage, and soft tissue envelope. Degree of comminution and osteoporosis. Factors related to the surgeon's capabilities as a surgeon. Possible treatment methods. Conservative treatment with cast, open reduction and internal fixation, combination of different types of external factors with or without internal fixation. Cast, open reduction, internal fixation, and different types of external fixations with or without internal fixation. Strategies for the optimal outcome. Restoration of the anatomy when there is injury to any articular surface, we must exhaust ourselves to obtain an anatomical reduction as possible as we can. Restoration of the tibial alignment and stabilization of the fracture to facilitate union. Understanding of the anatomy of the fracture should allow the development of improved operative techniques and outcome. Proper length and rotation, critical, very critical, length and rotation, preserving and maximizing ankle and subtalar motion. Even when these goals are met, there is no guarantee that the patients will have an acceptable result. First line of treatment, the non-operative treatment. Long leg cast for 6 weeks, followed by fracture brace and early range of motion exercises. It is indicated in type 1, Hatem and Elgohary fracture pattern, which is non-displaced fracture pattern. Also in severely debilitated patients. The patients that cannot be anesthetized or the anesthesia is risky for him. Manipulation of displaced fracture is unlikely to result in reduction of intra-articular fracture. So it is used in fractures with no displacement. The disadvantages of the non-operative technique or non-operative management is loss of reduction, which is common, and inability to monitor soft tissue status and swelling. The soft tissue is covered by the cast, so the surgeon cannot assess the status of the soft tissue. The displaced fractures are usually treated surgically. Helfet in 1994 was the first to propose a two-stage protocol. First stage, temporary external fixation to restore length, alignment, and rotation of the limb, with open reduction and internal fixation of the fibula if there is fracture in the fibula, and if the soft tissue around the fibula allows for fixation. The second stage, which is a definitive surgery, when the soft tissue have recovered significantly to limit the likelihood of complications. When to do the surgery? Proper timing of treatment is required to minimize soft tissue complications. Intervention must respect the underlying tissue and the amount of surgery that the soft tissue envelope can tolerate. Staged procedures are therefore often required to reduce complications and maximize the functional states. Skeletal traction, if more than few hours have elapsed since injury and evaluation, the soft tissue swelling will be too great to allow for immediate open reduction and fixation. In these situations, skeletal traction using calcaneal pen or external skeletal fixator should be used to prevent skeletal shortening while awaiting for soft tissue recovery, which may take days or weeks. Indirect reduction with traction helps to realign the fracture fragments, which makes subsequent internal fixation easier to accomplish. The definitive reconstruction through open approaches should be delayed until soft tissue swelling has decreased, as the tissues are tenuous and cannot withstand the surgical trauma. Surgery should be delayed for at least 10 days to allow the wrinkles to return, blisters to re-epithelialize, and wound to heal. In some cases, delaying the procedure for up to 4 weeks may be required to allow for soft tissue swelling to subside. Decision making. What kind of incision? Medial or lateral? What implant? Should the external fixator be used? And if used, it can be placed temporary or definitive treatment. Should treatment be staged or done at once? The goals of surgical treatment is to maintain the fibular length and stability, restoration of tibial articular surface, metaphyseal defect grafting, and buttressing of the distal tibia. Plating of the fibula to maintain the length, reconstruction of the articular surface, grafting of the metaphysis to avoid metaphyseal collapse and malunion, and buttressing plating of the distal tibia. Articular fracture reduction can be achieved percutaneously or through small, limited approaches, assisted by a variety of reduction forceps with fluoroscopy to judge fracture reduction. The metaphyseal fracture can be stabilized either with plates or with external fixator. Bone grafting of the metaphyseal defect. The internal fixation, like in all articular fractures, open reduction internal fixation is the most reliable way to obtain an anatomical reduction of the articular surface, as the principle in articular fracture, you must exhaust yourself to obtain an anatomical reduction as possible as you can. However, this option should be carefully weighted against the soft tissue condition and the comminution and number of fragments. After soft tissue recovery, a limited open reduction and stabilization of the articular components is done with screws alone or with screws and small buttress plate. Location of incisions and the steps of reduction are based on the preoperative plan. Soft tissue dissection should be minimized and the fragments should remain attached to the periosteum and the joint capsule. In internal fixation, as we said, the first step is the fixation of the fibula to regain the correct length of the tibia and to facilitate the three-dimensional orientation, and the reduction of the fracture. Several surgical approaches to the tibia have been described for the treatment of these fractures. Whatever the surgical route chosen, the surgical approach should be centered on the large bone fragment, and the care taken not to traumatize the skin with aggressive surgical technique. Arthrotomy is essential for accurate reduction of the articular fragments. Keep a maximum of 2 millimeters of incongruity of the articular surface. Incisions, the distance between the incisions should be no less than 6 to 7 centimeters. Anteromedial approach, anterolateral approach, posterolateral approach. The articular surface generally is reassembled from lateral to medial and from posterior to anterior. From lateral by following the anterolateral fragment and the posterolateral fragment of the fracture. As we said before, there is a large anterolateral fragment, Chabot fragment, and large posterolateral fragment and medial fragment. We start from lateral to medial and from posterior to anterior. From posterior to anterior for better visualization of the articular surface while reconstruction. The anterolateral portion of the tubercle of Chabot usually is still attached to the anterior syndesmotic ligament and is brought down into position at the time of fibular reduction. Once the fibular fracture is reduced and fixed with 1/3 tubular blade, the anterolateral fragment is regained its position. The anterolateral corner of this reduced fragment can be used as a guide for the restoration of the tibial nerve. When necessary, the split medial malleolar fragment can be retracted posteriorly to allow for better visualization of the articular reduction. Temporary fixation is obtained with K-wires, and the reduction is confirmed radiographically. Bone grafting of any structurally deficient areas in cortical or cancellous bone of the metaphysis then should be done. Fibular fixation, reconstruction of the articular surface, and grafting of any metaphyseal defect. When blade fixation is planned, an anterior or anteromedial buttress blade is used, depending on the fracture configuration. Large bone and T-blades no longer recommended, as they are bulky and can compromise the overlying soft tissue. Spawn blade, obsolete now. Internal fixation is done by 3.5 millimeters clover leaf blade. Has a much smaller profile, than the large fragment system blades, but still has adequate strength to maintain the reduction. Cannulate screws can be placed independent of the blade, either through the wound or percutaneously to secure isolated fragments. Fixation of the fibula with blade. The anterolateral fragment restores its normal position. Reduction of the articular surface starts from the anterolateral fragment and then proceeds medially. Fixation of the fragments by K-wires and cannulated screws over the wires. Filling the metaphyseal defects by bone grafts, either cancellous or cortical bone graft, as the condition requires. External fixation as a definitive treatment. This has been of interest in recent years, particularly for its benefits with respect to minimal interference with soft tissue. External fixators can be either unilateral or circular. They may span or not the ankle joint and may permit or not its motion. The principle of treatment with an external fixator is through ligamento-taxis. While most fixators are constructed to provide a tibio-talocalcaneal bridge, circular fixators allow a tibial-only assembly. This can allow early ankle motion, and depending on the size and orientation of the wires, a juxta-epiphyseal assembly and partial control over the comminution of fragments, which may be assembled under arthroscopic control. The assembly of the external fixator should not jeopardize the attainment of eventual coverage flap, not jeopardize the flap taking, not jeopardize the definitive fixation by plates, and not jeopardize the fixation of the fibula. In this frame, external fixator, tubular external fixator, is applied in position. Before securing the fixation of this frame, we should fix the fibula to maintain the tibial length. Articulating versus spanning external fixator. Non-articulating rigid external fixation. This is the most commonly used. Theoretically, it allows no ankle motion. Articulating external fixation allows motion in the sagittal plane. Hybrid external fixation may be used ring and a tubular system with fixation of the fibula to maintain the tibial length. Arthrodesis, seldom performed acutely. Reserved only for severe articular comminution, which is not otherwise reconstructable, best done after fracture comminution has consolidated, after consolidation of the comminution, and soft tissue have recovered. As regards open fractures present an additional challenge. Like all open fractures require emergency debridement, irrigation, and stabilization. The typical wound associated with an open Plafond fracture is a transverse distal anteromedial laceration. The proximal skin flap is contused, and use of the usual anteromedial incision may compromise its blood supply. Steps in treating open fractures: apply external fixator, obtain indirect reduction, stabilize the fibula, and perform the reconstruction of the articular surface through open wound with the use of cannulated screws for stabilization. Cancellous bone grafting and even internal fixation can be delayed until 4 to 6 weeks later when the soft tissue have been stabilized and the risk of soft tissue and sloughing and infection is reduced. The post-operative management: initial splinting in neutral dorsiflexion with careful monitoring of soft tissue, early and ankle foot motions, non-weight bearing for 12 to 16 weeks, then progression to full weight bearing as when there is radiological evidence of healing. Complications of Plafond fractures. Early complications include mainly the skin necrosis, and superficial and deep infection, also loss of fixation. Complications of the fracture healing: delayed union, non-union, varus or valgus malunion, non-anatomical reduction of the post-operative loss of reduction of the articular surface. Soft tissue slough, necrosis, and hematoma result from initial trauma plus improper handling of soft tissue. Soft tissue sloughing, necrosis, and hematoma either from the trauma from the start or the surgical procedures and bad handling, improper handling of soft tissue. So we must avoid excessive stripping, avoid skin closure under tension. When the skin is under tension, secondary closure, skin grafts or muscle flap may be required for adequate closure. Prevalence of post-operative skin and wound problems decrease substantially with the use of the technique of indirect reduction and two-stage fixation. Non-union accounts for about 5% of cases, occurs in about 5% of cases, result from significant comminution and bone loss, as well as hypovascularity and infection. Malunion either in varus or valgus due to non-anatomical reduction and inadequate buttressing followed by collapse or premature weight bearing. It occurs in about 25% of cases when external fixator is used. Infection, mainly with open injuries and soft tissue devitalization. Highest incidence with early surgery under unfavorable soft tissue conditions. Late infection complications may manifest as osteomyelitis. Post-traumatic arthrosis due to damage of the articular cartilage or inadequate reduction of the articular cartilage. The condition may clinically the patient may go well despite of the radiographic signs of post-traumatic osteoarthritis. Tibial shortening caused by fracture comminution and metaphyseal impaction or initial failure to restore length of the fibular fixation. Decreased ankle range of motion may occur as a complication with range between 10 degrees dorsiflexion and less than 30 degrees plantar flexion. Thank you.
Thank you so much, Professor Hatem, for this very interesting talk. Thank you so much, sir.
شكرا جزيلا لمحاضرة حضرتك يا فندم.
اتفضل يا
الله
بيه.
يحفظ دكتور محمود.
شكرا جزيلا لحضرتك يا فندم.
انا كنت ناوي بصراحه ان انا اتكلم فرانكو اراب بتبقى ألذ واجمل، فلما لقيت حضرتك قلت ان في ناس فورينر ممكن يبقوا موجودين، فانا كلمت المحاضره كلها بقى من غير حاجه عربي خالص.
ما فيش مشكله يا فندم، احنا يعني معظم اللي موجودين اخواتنا من الدول العربيه برضه، فهو ما فيش مشكله بالنسبه لنا ان شاء الله يا استاذنا.
بنستاذن حضرتك،
انت المودريتور مع الدكتور حاتم بيه. اتفضل يا دكتور محمود.
بنستاذن حضرتك يا فندم، بس هو كان في اول سؤال معانا، حد بيسال حضرتك when you do external fixator how is the ankle joint is maybe stiffness. هو بيسال عن الستيفنس في حالات الفيكسيتور.
هو الاكسترنال فيكسيتور هو احنا بنحطه لغايه ما يحصل سوفت تيشو هيلينج، ده في اغلب الحالات. انما لما بنستعمله حتى كديفينيتيف واي اوف مانجمنت، الحالات بتعدي بعد كده بفيزيوثيرابي وبعد ما بيحصل هيلينج الفراكشر وما بيحصلش ستيفنس من البدايه يعني ده قليل ان هو بيحصل. لكن في الحالات اللي هي السيفير كومينيوشن وسيفير سوفت تيشو انجري، الستيفنس اللي بيحصل ممكن يحصل نتيجه للفايبروز بتاع السوفت تيشو نفسه لما يكون في سيفير سوفت تيشو انجري.
تمام يا فندم. هو في سؤال تاني بيسال حضرتك، هو في فرق بين التايمينج اوف سيرجري ان هو يبدا at the first hours before swelling or delayed after the swelling subside، في فرق بينهم في الاوت كام؟
طبعا طبعا فرق. كل لما بتيجي بدري قبل السويلنج ما يحصل، ممكن ان انا اوصل للديفينيتيف مانجمنت من البدايه. انما بعد لما السويلنج بيحصل، السوفت تيشو كومبرومايز اللي موجود ده بيخليك تمشي في الستيج بروسيدور، يعني بتخليك انت تنتظر السوفت تيشو هيلينج اللي موجود، لانك مش هتقدر تفتح في المنطقه دي، ولا سيما ان السوفت تيشو في المنطقه ديت بيبقى ديليكت وبيبقى قليل، مفيش بالك سوفت تيشو، فالسوفت تيشو قليل، فالانجري السوفت تيشو السوفت تيشو كومبليكيشنز كتيره قوي في المنطقه دي. فلما بيحصل ديلي انت محتاج ان انت تستنى وقت اطول، ففي وقت بيضيع على المريض علشان منتظر السوفت تيشو هيل.
تمام. هو حضرتك سؤال تاني بيسال حضرتك how to reduce الارتيكولار سيرفيس في حالات اللي احنا بنستخدم فيها الاكسترنال فيكسيتور as a definitive treatment.
الاكسترنال فيكسيتور as definitive treatment بنستخدمه في تايب 1 رودي اند الجوهر. بحيث ان هو الديسبيسمنت قليل، او الحالات اللي احنا نقدر ان احنا نعمل لها ريدكشن للارتيكولار سيرفيس، او بنعمل اسوشيتد بنعمل مينيمال انسيجن ونصلح منه الارتيكولار سيرفيس ونثبته بكي وايرز وكانيوليت سكروز.
تمام.
انما طبعا الحالات اللي فيها سيفير كوميونيوشن ده يشد زي ما عدتها اكتر من مره، انا قلت ان anatomical in articular fracture you should exhaust yourself to obtain an anatomical reduction as possible as you can. ابذل قصارى جهدي ان انا اوصل لاناتوميكال ريدكشن. ففي السيفير كوميونيوشن طبعا بالمانيبيوليشن بالكلوزد واي مش هقدر ان انا اوصل لكده، لازم افتح واعمل ارثروتومي للجوينت.
تمام. في سؤال تاني لحضرتك بيسأل، هو احنا بنسيب العيان في قد ايه في اكسترنال فيكسيتور قبل عشان نستنى السوفت تيشو هيلينج، يعني السوفت تيشو سويلنج اللي موجود، وبعد كده نبدا الديفنت
دي مش ثابته، دي بتختلف من مريض للتاني، في من ايام لاسابيع، يعني كله على حسب السوفت تيشو. السوفت تيشو كومبليكيشنز اللي بتحصل دي يعني من السيفيريتي بتاعتها لا تستدعي وتحترم ان انا انتظر علشانها.
تمام. حد بيسأل حضرتك هل السي تي والام ار اي از مانداتوري فور تريتمنت اند ديسيجن ميكينج؟
السي تي بيساعدك في التحديد الكونفيجريشن بتاع الارتيكولار سيرفيس، زي الاكزيال فيو بتاع السي تي اللي كنت موضحه ده، اللي بينت فيه الانترولاترال فراجمنت ديت اللي بعمل ريكونستراكشن عليها، والبوسترولاترال فراجمنت والميديال فراجمنت. دي المين فراجمنتس اللي بتبقى موجوده في الفراكشن. طبعا هتلاقي فيه شويه كوميونيوشنز ثانيه وفراجمنتس صغيره، بس مش دي المين فراجمنت اللي بتبني عليها. فطبعا السي تي هيفيدك كتير قوي.
في سؤال تاني بيقول لحضرتك، هو يعني في اني رول للبوستيريور ابروتش ان بيلون فراكشرز؟ طبعا حضرتك جاوبت عليه في المحاضره.
طبعا في رول لما اكون انا مش قادر ان انا اعمل ريدكشن من انتيريور، فبحتاج ان انا اعمل بوستيريور، وممكن ادخل بوستيريور على طول لو انا عندي المين فراجمنت اللي هي البوسترولاترال فراجمنت، هي دي الفراجمنت الكبيره اللي انا اقدر يعني الانترولاترال رجعت مكانها وشايفها انا بالاندر ايمج ان دي راجعه مكانها ومكانها كويس، وعايز انا اعمل ريدكشن للبوستيريور، فانا ابتدي بوستيريور واعمل فيكسيشن في البوستيريور. هو احنا لما قلنا احنا بنعمل فيكسيشن من الانتيريور للبوستيريور ومن اللاترال للميديال، ده على اساس ان الابروش معظمه انتيريور. انما لو انا عامل الابروش بتاعي انا داخل بوستيريور لاترال، ابتدي اعمل ريدكشن بوستيريور لاترال. هو الهدف الفيجواليزيشن، يعني انا ببتدي باللي انا شايفه، علشان لما اقفل المنطقه ما يعني اعمل ريدكشن لجزء هيقفل الرؤيه للي بعده، فببتدي بالبعيد عني لغايه ما اوصل للقريب.
حاتم بيه، may I have a question please sir؟
اتفضل يا فندم.
بالنسبه للكوميونيتد تيبيال بلافون فراكتشرز في الدايابيتيك بيشنتس، هل سعادتك بتاخد سبيشال بريكوشنز او في سبيشال ريكومنديشنز للتريتمنت؟
هو حضرتك على حسب الديجري بتاعت الدايابيتس بتاعته، هل هو ما في دايابيتيك بيشنت وزيه زي الهيلثي بيشنت، البون كواليتي هي اللي بتحكمنا. البون كواليتي بتاعته لو البون كواليتي كويسه خلاص هو نفس البروسيديور بتاعنا. هل هو دايابيتيك بيشنت وحصل معاه فراكشر في البلافوند وهل هو شاركوت مثلا؟
لا مش شاركوت، انا يعني انا بتكلم على السبيشال بريكوشنز عشان ما ندخلش في شاركوت.
طبعا الدايابيتيك بيشنت بعمل كنترول للدايابيتس كويس جدا قبلها، وبعتمد على الكواليتي اوف البون، هي الكواليتي اوف البون اللي بتحكمنا هنا في المانجمنت. والبوست اوبراتيف مانجمنت والكير بتاع الدايابيتيك بيشنت لازم طبعا ياخد كير اعلى، سواء سيستميكالي من حيث ان انا اكيب البلاد شوجر ليفل وزن نورمال طول الفتره بتاعت السوفت تيشو هيلينج، واثناء التكنيك نفسه بتاع العمليه اراعي ان البون كواليتي بتاعتي على حسب البون كواليتي، يعني اسس الكونديشن كويس والفيكسيشن بتاعي.
تمام يا فندم. في سؤال اخير بس لحضرتك، هو بيسال حضرتك يعني حضرتك بتفضل بيرسونالي تاخد البون جرافت من انهي مكان؟
باخد البون جرافت من الالياك كريست هنا في المنطقه دي.
تمام. شكرا جزيلا لحضرتك يا فندم، وشكرا جزيلا لوقت حضرتك يعني، وشكرا على المحاضره الرائعه.
الله يحفظك.
شكرا جزيلا استاذنا الفاضل استاذ دكتور
الله
حاتم
يخليك.
بيه الجوهري على المحاضره الاكثر من رائعه دي يا فندم. ثانك يو سو ماتش سير.
ربنا يخليك.
دلوقتي